Hi guys, welcome back to these deliberations in obstetrics and gynecology. I know you have an exam coming up and you have 19 subjects to revise. I thought I'll just help you with some topics of obstetrics which are likely to come. So let's take a quick look scan at these important topics. So we'll talk about engagement of the fetal head. What do you mean by engagement? Engagement is defined by a rule of 5 that if you divide the head into 5 imaginary parts, that you draw 4 lines just like shown in this picture, and you divide it into 5 imaginary parts. So when the head is getting into the pelvis, see, this is one part and the second part, third part. So if 3 or more parts of the fetal head have gone into the pelvis and 2 or lesser parts are outside the pelvis, then we say the head is engaged. So when less than equal to 2/5, when less than equal to 2/5 parts are felt outside the pelvis and 3/5 have gone inside the pelvis, we say the head is engaged. So engagement occurs when the primary gravidas are at 36 weeks, and when the head gets into the pelvis, they feel a sort of a lightning. That means lightning, not like thunder, lightning in the sense that the head gets into the pelvis and she feels much lighter because the abdomen is full of a baby, and that head, when it gets into the pelvis, the mother feels much lighter. And multigravida, it occurs in the established labor, it occurs in labor because the abdomen is a little pendulous in multiparous women, multigravida women. So the head is not in the straight linear axis of the pelvis. So the baby is a little forwards in a pendulous abdomen. So when the uterus starts to contract, the uterus will make the baby straighten up, and that's why during labor the head engages in a multigravida. All right, so let's move on and see a quick fire look at all the major parts of the labor topic. What is the most common presentation? Cephalic is the most common presentation. Part of the fetus in the lower segment is called the presentation. Now, part of the presentation on the internal os is known as the presenting part. So, what is the most common presentation? Cephalic presentation. Most common malpresentation is breech, which is 3% of all the pregnancies at term. And most common presenting part, like I defined just now, most common presenting part is the vertex. Okay, the part of the presentation on the interloss is known as the presenting part. So most common presenting part is the vertex. So if you see that this is the cephalic presentation, and in this cephalic presentation the vertex is the most common presenting part, and the denominator of the vertex is the occiput. All right, so most common position of vertex, most common position of vertex is left occipitotransverse in 40% of cases, and the second most common is left occipito anterior. All right, guys. So, what is the most common malposition? Most common malposition is right occipito posterior. And please remember, this was a very famous AIMS question. What do you do in a case of occipito posterior? Wait and watch. Why? Because just now I told you that occipito-posterior, if it comes, it can rotate to occipito-anterior. Look here, guys. If this is occipito-posterior, generally towards the right it is. So right occipito-posterior is the most common. It will hit the pelvic floor and it will rotate to occipito-anterior and deliver by extension. Or it may stay occipito-posterior in a case of anthropoid pelvis where the side walls are parallel, the rotation is not possible. If it stays occipito-posterior, it can still deliver by extension, and it is that just that the face will be looking at the pubis. So we say it's a face to pubis delivery in a occipito-posterior, which stays occipito-posterior in a case of an anthropoid pelvis, but both will deliver. All right, so occipito-posterior, what do you do? Wait and watch because it delivers. All right, guys, so let us see occipito-posterior. In 80% cases, when there is a gynecoid pelvis, there is a right occipito-posterior which rotates to occipito-anterior, and it delivers easily. Then, if it is a case of a anthropoid pelvis, in a case of anthropoid pelvis, it stays persistent occipito-posterior, POP for persistent occipito-posterior, because the side walls are parallel, and there is no rotation possible. Okay, MCI guys, and also INSCD guys, this question has come many times. Which type of pelvis there is no rotation possible? That is anthropoid pelvis. It stays persistent occipito-posterior. It delivers by face to pubis. Okay, FTP I've written. Okay, I'll write here face to pubis. Then in 2 to 4% cases of android pelvis, there is rotation. It rotates to occipital transverse and stops. So then what you can do, it goes till occipital transverse and stops, because in android pelvis, the front pelvis, the fore pelvis is very narrow. So the anti-rotation does not happen. It rotates from occipital posterior to occipital transverse and stops. So then you have to put a hand inside and do a manual rotation and do a forceps extraction. So manual rotation, forceps extraction can be done, or you can also do a forceps rotation and forceps extraction, which of course is done best in trained hands. So manual rotation forceps extraction can be done in a case of a android pelvis, where there is occipital posterior turning to occipital transverse and stopping. But remember, in this occipital transverse, if it is in the hospital, this is what is done. But there are cases which are neglected, like let's say in the periphery, a woman was delivering, the head was in occipital transverse. No occipital transverse will deliver. Occipital transverse can never deliver like this. It has to hit the pelvic floor and rotate to occipital anterior. So occipital posterior also, which becomes occipital transverse, will not deliver. So yes, if it is in a village and the thigh has given up because she's not able to understand that it's transverse and it won't deliver, she finally gives up, send the patient to the big hospital, and there you do a PVNC. The head is totally edematous, and she's been in second stage for a long time, and you can barely feel the bones. You can only feel a big, large caput, and there is no lica because it's all drained off in the second stage. So, in such neglected cases of occipital transverse, we call them deep transverse arrest. So, they ask you deep transverse arrest, that you cannot do anything else but a cesarean section. All right. Right, guys? So that is the picture of what I was just trying to tell you. So in a gynecoid pelvis, can you see if this arrow, if you imagine this arrow to be the occiput, the arrowhead. So in a case of a gynecoid pelvis, this will rotate one eighth, another one eighth, and another one eighth of the circle. So 3/8 anterior rotation. So gynecoid pelvis rotation happens and delivery will occur. In an anthropoid pelvis, the side walls are parallel and this rotation is not possible. So this stays persistent occipital posterior and delivers by base to pubis. In a case of android pelvis, it rotates partly to occipital transverse and further rotation is not possible. So you can do manual rotation, forceps attraction. So rotates to occipital transverse, then you can do manual rotation, forceps extraction, or you can do forceps rotation and forceps extraction. But remember one thing, guys, that this patient, the last one, this one which I was discussing, if it is a neglected occipital transverse, suppose she was delivering in a village and the dye could not do anything about it because she doesn't know it's the occipital transverse which is not going to deliver, and after 2 or 3 hours of waiting in the second stage, finally the dye decides to send this woman to the big hospital, the government hospital, and you happen to see that patient, and now the head is totally having a big caput, the liquor is all drained in second stage. So in that cases, when the head is stuck in the transverse plane, the occipital transverse plane, and the head is edematous and the liquor is drained, so you cannot even hold the head properly. So forget rotating, you may not be able to even hold it with your hand. So such neglected cases of occipital transverse are known as the deep transverse arrest, and maybe I'm giving you a very dramatic condition. Much before this, we call it a deep transverse arrest, and then we do a cesarean section. So if they ask you deep transverse arrest, go ahead and say cesarean section. So, what are the cardinal movements of labor? There are 7 cardinal movements of labor, and the first one is engagement, which we already discussed. So, second one is descent. Now, how is descent seen? Descent is seen in relation to the ischial spines. Can you see? These are the ischial spine. In relation to these ischial spines, we see the descent. So let's say this is a case of occipito anterior, and when we see the descent, it's in relation to the ischial spine. So when we do a PV, we put a finger on the ischial spine and see the presenting part, which is the vertex, and we feel the denominator. Can you see? I'm feeling the denominator at the level of the ischial spine. So this is the parameter. The ischial spine is a parameter relation to which we see the descent of the head. See now the occiput, okay, is at the level of the ischial spine. So that is what is a zero station. Okay, so that is occipito anterior, and we saw descent. Next is ongoing flexion, and now the head will hit the pelvic floor and rotate. So when the head hits the pelvic floor, it rotates to occipito anterior. Look, the most common is occipito transverse towards the left. So when left occipital transverse hits the pelvic floor, it rotates to occipito anterior and it delivers by extension. So that happens at the pelvic floor. So internal rotation happens at the level of pelvic floor. After the internal rotation, the head delivers by extension. Now it corrects the internal rotation. So that is what is known as the restitution. What is that? Remember, the internal rotation. Internal rotation is because of the pelvic floor. So moment the baby comes out, it has a turn in the neck. It corrects the turn in the neck, and that correction of the turn is known as the restitution. Okay, the correction of the internal rotation after delivery is known as restitution. Now when the baby's head is out, the baby's shoulders will hit the pelvic floor. Now when the shoulders rotate on the pelvic floor, the head is rotating outside. So that is what is known as external rotation. So shoulder rotation on the pelvic floor causes the external rotation of the head. So internal rotation occurs at the pelvic floor. Delivery by extension. Restitution is the correction. It is a correction of internal rotation, and external rotation is shoulder rotation. Shoulder rotation on pelvic floor. Right, guys? So let us quickly have a look at the breech vaginal delivery. Breech will deliver. Please, breech will deliver, especially in a multi-grader. Go ahead and do a breech vaginal delivery. Don't be scared. If you worked in obstetrics, you can do this delivery. Even a primary breech will deliver. Yes, the same big hospitals which tell you that we should do only cesareans for breech, they actually ask a lot to the postgraduates that how to go ahead and do a breech vaginal delivery. So please don't say breaches are not delivered vaginally. Yes, in private practice, all breaches are delivered never delivered vaginally. They're all delivered by cesarean. In fact, in private practice, I've seen no deliveries are done vaginally these days. Most of the patients end up in cesarean section on some or other pretext. So yes, because there is so much of litigation, so doctors are a little scared. That's why these things are increasing. Never mind, not the time to discuss on those things. Let's move on and see breech vaginal delivery will happen. So what is the it will happen in a institutional setup only in big institutes, okay, like AIMS, RML, Safdarjung, my hospital, St. Stephen Hospital, we do a lot of breech vaginal delivery. So in such big places only you will do, because there'll be a provision of doing a delivery under the supervision of a senior obstetrician. And if it doesn't happen, you can quickly take the patient even at 2 a.m. in the morning for a quick cesarean section. So breech vaginal delivery, the most common breech is the extended breech, and it is the best for vaginal delivery. So there is flex breech. You can see the legs are flexed, the knee joints are flexed here. Extended breech, you can see the knee joints are extended. Footling breech, the one leg is outside and one leg is inside. So footling breech is not so common. So most common breech is the extended breech, and extended breech is the best for vaginal delivery. All right. So breech will deliver vaginally, and the most common is the extended, also known as the frank. Okay, yes, this flex breech will also deliver vaginally. So extended is the best, flex will also deliver vaginally, but footling breech always ends up in a cesarean section. Mind you, even an extended head, I'm not talking about an extended breech. Extended breech will deliver vaginally. If there's an extended head and you see on the ultrasound, extended head, if you see on the ultrasound in a breech presentation, go ahead and do a cesarean section, because the breech will deliver, the body will deliver, but the head which is extended will get stuck. So the after coming head will get stuck. So we never do a breached vaginal delivery when the head is extended on the ultrasound. All right. Now in breech, when we're doing the delivery, do not touch the baby till the umbilicus is delivered. So once the breech comes out and the umbilicus of the baby is delivered from the vagina, that's the time when you try to deliver the legs, and then you try to deliver the thorax of the baby and the arms. So for breech vaginal delivery, remember the legs and the arms. If they are flexed, they are easy to deliver. If both the legs and the arms are extended, then it is difficult to deliver. So for the flexed legs, you have to simply hold the legs. When the breech comes out, the legs will also are flexed. They will simply hold the legs and pull them out. But if it is extended legs, then you have to do the Pinard's maneuver. Pinard's maneuver is that you go along the hip, then go to the thigh and tap the popliteal fossa. The legs will flex and you take out the legs. That is Pinard's maneuver. Now, if it is flexed arms, you have to, the arms will be flexed like this. You're from the back of the baby. You just hold the arms at the cubital fossa and straighten them, and they'll come out easily. But if the arms are extended, for the extended arms, you have to do the love sets maneuver. Okay, so extended arm, you have to do the love sets, and for the extended legs, you have to do the pinards. All right. Now, after coming head of the breech, remember that after coming head of the breech is that very important part in which the babies can get very sick. So, till the cervix is not fully dilated, do not allow the mother to deliver the breech. Always wait for the cervix to be fully dilated and wait for the baby to come till the level of the umbilicus, then only touch the baby. That's what is known as assisted breech vaginal delivery. Do not do a breech extraction, and do not let the spontaneous breech delivery also happen. So always do a assisted breech vaginal delivery. That means touch the baby only after the baby is delivered at till the level of its umbilicus. Okay. Now after coming head of the breech, the one of the techniques which you can do is malar flexion and shoulder traction. Put your hand into the vagina, go and hold the malar bones, put your fingers on the malar bones, flex the head and do shoulder traction. Or you can also do a jaw flexion, because while doing malar flexion, sometimes you can injure the eyes. So malar flexion and shoulder traction, also known as the jaw flexion, because you can put a finger in the jaw and do the flexion. So malar or jaw flexion, shoulder traction, known as the Mauricio Smelly Viet, MSV. We also call it the MSV, Mauricio Smelly Viet technique. Then we have the Burn Marshall technique. The head is now inside the vagina. If you see, the head is inside the vagina. The complete baby has come out. So this baby and the head is inside. So while supporting the baby, you turn the baby upwards like this, and the head pops out with flexion. Turn the baby in a large arc of a circle. That is what is known as the Burn Marshall technique. But you have to wait till you see the nape of the neck. You do this Burn Marshall not when you start seeing the base of the neck. Till you see the nape of the neck, you will not do the Burn Marshall technique. And last but the most safe procedure is to do forceps of the after coming head, and that forceps is the, this is the safest method, and that is the Piper's forceps. It's a little short and has hardly any pelvic curve because it's a direct application on the side of the head, and that is what is Piper's forceps for breech. Quick scan of the topic of PPH. So, when we talk about postpartum hemorrhage, the most common cause of maternal mortality in India is still PPH. Look, when you read Western books, they will say most common cause of maternal mortality is thromboembolism. So please don't get confused, because we are going to ask you only Indian data. So most common cause of maternal mortality in India is PPH, and PPH should be, the drug of choice is oxytocin, but we must do active management of third stage of labor. So when the baby is delivered and the plaster delivers and then you give oxytocin, it will work. It is a drug of choice. But if you give it a little earlier, which is known as active management, you may have much lesser bleeding. So that's why what are the parts of the active management of third stage of labor? The first is giving oxytocin with the delivery of the anterior shoulder of the baby. When the head comes out, the broadest part of the baby is the bipedal diameter, and the next broadest are the shoulders. Sometimes the shoulders are big, like in a case of a diabetic mother. So when the head comes out and then the shoulder comes out, we know that the delivery will complete. And the shoulders come out, that means there's no shoulder dystocia. So that's the time when the anterior shoulder of the baby comes out, we are very sure now the delivery will complete. So give oxytocin to the mother, mostly 10 international units intramuscularly is given. You can give IV also. So you give oxytocin to the mother, and after that the posterior shoulder is delivered, the body of the baby is delivered, the legs are delivered, and then you do the control contraction delivery of the placenta, which will take another 5-10 minutes. And with that, by the time you have completed the delivery, then you have got enough time by which the peak action of oxytocin will set in, and there'll be hardly any bleeding after delivery. So that's why oxytocin at the delivery of the anterior shoulder, 10 international units you can give intramuscularly. And then you'll do delayed cord clamping, that is more than 60 seconds, more than 1 minute. See, a lot of people say 30 seconds, but now what we have to answer is 60 seconds, so that some blood from the placenta can drain into the baby. All right, so wait for more than 60 seconds. And then control cord traction, which is known as the Brandt Andrews technique, the best method of delivery of the placenta. You give a gentle tug on the cord and counter traction on the uterus. And the last but not the least, definitely very important part of the management is a gentle uterine massage. Guys, be very sure that uterine massage is done. Okay, please, you do not do a bimanual bimanual compression because it's very painful. Okay, gentle uterine massage is done, and there is no controversy in this. Yes, it has come in your INICT exam twice in the last 2 years, that what are the series of events, what are the chain of events to follow when you're doing active management of third stage of labor, and uterine massage has always been in the choice. In fact, in the INICT last exam, they asked you which of the following is not done, and of the choices, the one which you cannot do is the bimanual compression because it's painful. In fact, most of us do a little bit of bimanual compression also, but that's known to be painful, so it is not advised to do it. Okay, so go ahead and do a uterine massage. Now there's another question which has come: which of these four is the least important part? Actually, the part where we say delayed cord clamping. Yes, this is not a very important part. Other three things are more important. So delayed cord clamping is done in India because we want babies of the poor mothers, poor Indian people, to have some hemoglobin at least. Otherwise, if you read a Williams, we actually do early cord clamping. But yes, when you're writing an Indian exam, you have to do delayed cord clamping. And that is also given in your book, that if you can do early cord clamping or delayed cord clamping, it doesn't have any effect on the PPH incidence. All right, guys, so let's not get confused about this. Delayed cord clamping is done, but it is not the most important part. Other three are very important. Right, guys. So least important of these, yeah, that was the reminder for me. Now, when we say that the regular drugs, like you've done oxytocin, then you did the oxytocin analog carbetocin, and you've also done let's say methylergometrin and carboprost, the go-to drug. If none of the drugs work, you tried even misoprostol. If nothing works, then the go-to drug is carboprost. Even if that doesn't work, get into surgical management, and the first management generally what we do is a balloon tamponade. If that doesn't work, we cut the abdomen, deliver the uterus outside the abdomen and put a B-Lynch suture. And if that doesn't work, we can try uterine artery embolization. But what is next? You have to start doing the methods of uterine devascularization, which is first is uterine artery ligation, then the internal iliac artery ligation. Of course, before internal iliac artery ligation, we'll do also the ovarian artery ligation. So the step of devascularization is uterine artery ligation, ovarian artery ligation, and then the internal iliac artery ligation. So when you're doing the internal iliac artery ligation, remember the anterior division has 7-8 branches, and the posterior division has only 3 branches, which is superior gluteal, iliolumbar, and lateral sacral. So you can remember as short gills. Fishes have short gills, or you can remember as Shubman gills. All right. So these are the 3 posterior division branches. Mostly the questions are very simple. All of the following are anterior division branches, except all of the following are posterior division branches, except. And with this mnemonic, you can remember. But nowadays they're asking you even better questions. That which artery is ligated when you're doing internal iliac artery ligation. So please remember, we are ligating the internal iliac artery, correct? But which branch? We are ligating only the anterior division. Okay, we are not ligating the posterior division. Only the anterior division ligated because you're reducing, not stopping. You're reducing the flow in the anti-division of the internal iliac artery, so that the flow in the uterine bed is sluggish, and sluggish blood flow promotes thrombosis. All right, guys, so that's the principle here. Let's move on. So, what is the etiology of hypertension in pregnancy? Remember, the blood vessels in pregnancy after 20 weeks, every woman who is pregnant, the blood vessels will become more vasodilated, because if you see in the beginning of pregnancy here, if you see here, the spiral artery which is supplying the blood to the placenta. See, this is the blood in the placenta, and the villi are dipped into the placental pool of blood, and this fetal villi will suck in the nourishment from the maternal blood. Of course, no fetus takes the blood from the mother. Babies just dip their villi into the maternal blood, and then they take the nourishment out of the blood. The mother never gives the blood to the baby. Mother could be A positive, the baby could be a B negative baby. All right. So any baby can live in any mother's uterus, because the blood is never exchanged. It's just that the nutrition is sucked in by the villi. So now we need more blood in the placental bed. So more blood comes by the spiral arteries of the mother, and the spiral arteries, can you see the architecture in the first trimester here, and see in the last trimester here? The blood vessels, muscle is totally replaced by trophoblast. So when the muscles are replaced by the trophoblast, the vessels are vasodilated, and vasodilated blood vessels will give more blood into the placental bed, and more nourishment to the baby happens. Now, if this trophoblastic replacement of the spiral arteries is inadequate, then there is a vasospasm. So inadequate changes of pregnancy, persistence of previous vasculature, that causes vasospasm in the spiral arteries. So to overcome this vasospasm, because vasospasm will reduce the flow in the placental bed, so to overcome this vasospasm, mother increases her blood pressure. But yes, that blood pressure doesn't increase only in the spiral arteries or in the placental bed. That blood pressure increases all over the body. So high blood pressure goes to the kidney, destroys the kidney. High blood pressure goes to the liver, acinar damage, subcapsular hematoma, cause of the epigastric pain, isn't it? And then same thing, high BP will damage the eye, uh, proliferative retinopathy, and even papilledema. And also they can also be insult to the brain, release of glutamic acid, convulsions, microangiopathic hemolysis, so DIC, so many things can happen because of the high blood pressure. So yes, that's because of vasospasm. This vasospasm is also promoted by some factors like vasoconstrictors are increased, that is the thromboxane A2, and increase in angiotensin, and there is reduction in the vasodilators like prostacyclin, that is PGI2, and there is reduction of the vasodilators like nitric oxide. So this will contribute to the vasospasm. What else contributes to the vasospasm? That in pregnancy we need angiogenesis, we need more blood vessels. So angiogenic factors like transforming growth factor and vascular endothelial growth factors, they reduce, because the transforming growth factor is bound by something called the soluble endoglin, and the vascular endothelial growth factor is bound by something called soluble FMS, like tyrosine kinase 1. So we actually call it SFLT1. So these growth factors are bound by these limiting anti-angiogenic factors. So angiogenesis is less, vasospasm, more vasoconstrictors, lesser vasodilators, more vasospasm. So basically, we always say pregnancy-induced hypertension. If you remember, it is placenta-induced hypertension. I'm very happy with your understanding. So when we talk of management of eclampsia, okay, treatment of choice for eclampsia. I'm not talking about hypertension OPD, where the drug of choice is labetalol. For eclampsia, the drug of choice is magnesium sulfate by the Pritchard regime. We have to give the Pritchard regime. All other regimes, they're all outdated. Only Pritchard regime is given, and that is what is asked in the exam. So the dose is 4 grams Please don't say milligrams. 4 grams IV plus 10 grams intramuscularly. IV is in dilution, it is diluted, and 10 grams is split, 5 grams into right buttock and 5 grams into the left buttock, because for giving 5 grams, it's 10 ml of volume of magnesium sulfate. So we add actually 1 ml of lignocaine to each of these two injections, so that when the muscle gets the injection, it doesn't hurt her so much. Okay, it's instant pain relief also with the lignocaine. Best definitive management of eclampsia: when a patient has vasospasm and high blood pressure, and she's in the worst case scenario that she has eclampsia. Next, she's going to have DIC and bleeding from multiple sides, and cavernous sinus thrombosis, and she can actually die because of eclampsia. So best definitive management is terminate the pregnancy, termination of pregnancy. Because I taught you just now in the revision class also, what is the main cause of hypertension pregnancy? Vasospasm. I told you it is, rather than calling it pregnancy induced hypertension, you should call it placenta induced hypertension. So what is the best definite management? Take out the placenta, and the patient has normal blood pressure. Obviously, when you take out the placenta, before that, you have to take out the baby. So, yes, best definite management is termination of pregnancy. More than 90% of patients will have normal blood pressure in the following 1 week. 90% patients will have normal blood pressure in the following 1 week. Continue Maxil for 24 hours after the delivery or the last convulsion, and the dose is now 5 grams 4 hourly. Okay, you have to monitor maximum. Hot shot question for Neet PG and even for MCI. So monitoring maximum regime is very important, because magnesium sulfate is a cerebral suppressant. So when the brain is suppressed, and yes, knee jerk is a upper motor neuron reflex. So knee jerk is a upper motor neuron reflex. So when the brain is suppressed, the knee jerk will be also suppressed. So to see the magnesium sulfate is not causing toxicity, we must actually see the knee jerks. And if the knee jerks are present, if the knee jerks are present and the respiratory rate is more than 14 times in a minute, the that means the brain is not suppressed. Now, magnesium sulfate has a renal excretion, so urine output in the last 4 hours should be more than 100 ml. So yes, giving this 4 hourly. In this 4 hour, the knee jerk should be present, the respiratory rate should be more than 14 per minute, and the urine output should be more than 100 ml for the last 4 hours. If these are good, then we give the next dose. If any of this is not good, there was a question in NEET exam that the last 4 hours the output is only 70 ml. So what do? You withhold the next dose of magnesium sulfate. All right. So what are the therapeutic levels of magnesium sulfate? So therapeutic levels is 4 to 7 milliequivalents distributed per liter. That is what is the therapeutic level. First sign of magnesium toxicity is if it is more than 8 to 10 milliequivalents, and that is knee jerk suppression. So knee jerk is the suppression of knee jerk is the first sign of magnesium sulfate toxicity. If it is more than 15 milliequivalents per liter, it causes respiratory arrest. And if it is more than 25 milliequivalents, it causes cardiac arrest. So treatment of toxicity, if there are these signs, it is calcium gluconate. And calcium gluconate, all of you know, it is given 1 gram. It is given 1 gram intravenously in 10 ml in 10 minutes. All right, that is the management of magnesium sulfate toxicity. So when you want to give tocolysis is to stop the labor. When do you want to actually stop the labor? If the patient is in labor at term, we don't want to stop it. If it is preterm, we want to stop it because the baby might be premature and having highly membrane disease, respiratory distress of newborn, ICU stay, neonatal death. So many things can happen. So tocolysis indication is if the dilatation is less than equal to 3 centimeter, that the patient is in latent phase of labor and gestation is less than equal to 34 weeks. because lung maturity occurs by 34 weeks. If the lung maturity is not has not happened, that means the patient is preterm labor at 32 weeks. Then only we give tocolysis. If a mother is in labor at 36 weeks, I know it is preterm, but the lung is already mature, so we don't actually stop that labor. What is the purpose then to stop labor when it is preterm labor? To get at least 2 days for the steroid action. You know what? If it's an established case of preterm labor, you will not get more than 2 or 3 days of stopping. All right. So tocolysis purpose is lung maturity achievement, lung maturity by steroid administration. Try to get at least 48 hours of stopping of preterm labor so that the steroid action happens and the lungs get mature. All right. So what are the tocolytics? Beta agonists like salbutamol, and we also have drugs like terbutaline, ritodrin. All of these drugs are good drugs, but these beta agonist drugs are also known to cause severe tachycardia and pulmonary edema, and they're also known to cause gluconeogenesis, and that causes increase in sugars. So that's why these are not the best drugs. They have a side effect of worsening a mother who is already a diabetic. So it is generally avoided in diabetics because of the gluconeogenesis. Calcium channel blockers are the drug of choice, and that is nifedipine. And why nifedipine is the drug of choice? Because it is safe even in cardiac patients. Because this calcium channel blockers has the least incidence of pulmonary edema. That's why nifedipine is the drug of choice for patients with preterm labor. 10 milligrams 3 times a day is the dose. Calcium channel antagonist, and that is magnesium sulfate. Actually, magnesium sulfate is my favorite drug, and I give a lot of this for preterm labor because it's the only neuroprotective. It is the only neuroprotective agent. What is the meaning of neuroprotection? Reduces the incidence of cerebral palsy in the newborn, which is a newborn of in a preterm labor. So reduces the incidence of cerebral palsy. That is what is the meaning of neuroprotection. But yes, it causes some neonatal hypotonia. That's why it is not the drug of choice. PG synthetase inhibitors like NSAIDs we can give. Generally, indomethacin is a very good drug. We give it for preterm labor, but remember, we cannot give it after 32 weeks. It is not given after 32 weeks because it will cause a premature closure of the ductus arteriosus. Progesterone is the safest tocolytic. Please remember this part, guys. Safest tocolytic is the progesterone, and this progesterone is known to cause, good prevention of preterm labor rather than treatment. Nitric oxide donors, again, this is a smooth muscle relaxant, and that is also a good drug to give. Now, there's another tocolytic called atosiban. Atosiban, I don't know, sometimes you keep telling me that this is the drug of choice because it's a perfect oxytocin antagonist. Yes, indeed, the question came in your exam, name a oxytocin antagonist. And that's the only question which has come on atosiban because how effective it is. Look, this drug has not been approved for tocolytic action in America. It is told that it is not even better than the placebos which are given for the management of preterm labor. That's the kind of impression and that's the kind of effect it has to the Americans. So they don't use it at all. It is not approved. But the Europeans and the Britishers love this drug. So when there is a controversy between these two major colleges, it's never going to be taught to you as the drug of choice. Yes, Etozaban is used in private practice. It's a very expensive, good drug, they say, but the drug of choice is nifedipine. Etozaban is a perfect oxytocin antagonist. You can read your Williams. It is categorically writing in the last three editions that it's not approved for the management of preterm labor. Etozaban. All right, guys. So that was a quick fire revision. If you want to read, fatafat about a few topics like ectopic pregnancy, inversion of uterus, shoulder dystocia, signs of pregnancy, early pregnancy diagnosis, types of placenta and their complications, Leopold maneuvers, post-menopause bleeding, guys. Remember, it is CS cervix in India. Okay, I've given you a complete finding of a latest Indian study in the recent revision YouTube videos. So please go ahead and see those also if you have time. And then remember, biophysical profile, and perineal tears. If you want to read about them just before the exam, there's a short video which is there. There are two, three videos. In fact, the links are there in the bio. Please see this so that you can revise quickly about all the topics of obs and gynae. Otherwise, do a very good exam, guys. I want you guys to be confident about the effort you put in, and I'm sure success will always be there waiting for you guys. Best wishes. See you after the exam.